Hello, everyone. This is Dr. Shaveen Riazadi. Thank you for joining us on the presentation of History of Race in Medicine. We'd like to begin by letting you all know who the designers of this presentation are. We'd like to start with Dr. Michelle Williams, Dr. Alice Yan, and myself. This presentation was designed or has been designed for a continuing education course, and we hope that you enjoy it. The objectives of these presentations, or what we hope they will be able to learn, is the biological and social evolvement of race in medicine, discuss how race was used in clinical diagnosis and decision making, and the implications for health and healthcare disparities, identify examples of individuals in U.S. history who have contributed to reducing health disparities. We will begin with detailing how race was used to shape the development of medicine throughout U.S. history. We will provide a glimpse of historical timeline of significant events contributing to U.S. medical practice, education, and research. We will discuss some of the research that have contributed to advancing health equity and discuss future directions for health equity through research. Race is a complex construct that is not uniformly standardized or measured across different contexts. Racism in healthcare is a deep-rooted problem in our country, and the use of race in medical research and treatment is often inaccurate and inconsistent. Understanding race in medical research should start with how race was used over time. And we will embark on a historical journey that commences in the year 1972 until the year 2020. We will begin in 1972 with Dr. Benjamin Rush, who diagnosed blackness as a particular kind of leprosy, naming blackness as a disease state. By the 1800s, for white physicians in the South, the goal of medical practice was to improve the efficiency of plantation labor of enslaved people. In 1839, Samuel George Morton wrote Crania Americana, in which he claimed that black people had smaller skulls than white people and thus smaller brains, implying a lack of intellect. In 1846, the spirometer was invented and incorporated race-based corrections. This was based on the biological assumptions of smaller lung capacity for black and Asian patients compared to their white counterparts. In 1847, Dr. J. Knott asserts that the Negro achieves his greatest perfection, physical and moral, and also greatest longevity in a state of slavery. In 1864, Dr. Rebecca Lee Crumpler became the first African American female doctor. She championed African American women in medicine. However, prior to Dr. Crumpler, we must acknowledge the contributions of black midwives. The unofficial black medical practitioners were integral to maintaining the community's health. Black midwives played a crucial role in maintaining health of enslaved women and the newborns, and often tended to the slave masters' pregnancies. Although they were not recognized as licensed practitioners, midwives were highly valued members of the communities and maintained community connections and ancestry records. Howard University Medical School was founded in 1868, the oldest HBCU medical school. It provided medical education for black students excluded from predominantly white medical schools due to racism. In 1879, Mary Eliza Mahoney became the first African American licensed nurse. She began to work at New England Hospital for Women and Children as a janitor, cook, and washerwoman. She later got the opportunity to work as a nurse's aide. She applied and was admitted to the facility's nursing school, one of the first in America, in the year 1878. It is said that 42 applicants were admitted to the program and only 4 completed the 16-month program. Mary was one of the 4. In 1899, Webster wrote about the social determinants of health. saying differences in health outcomes for blacks and whites have more to do with living conditions than genetics. 1910, the Flexer Report led to the closure of almost all black institutions for medicine, characterizing them as underperforming. In 1913, President Woodrow Wilson joined institutionalization segregation by applying separate and equal to the civil service. In 1916, the California State Board of Health Monthly Bulletin wrote about the black Mexican immigrants as a type of people who bring typhus and other diseases in California from Mexico, and denounced them as unable to assimilate and less intelligent than white Americans. In 1932, the infamous Tuskegee syphilis study began, a 40-year experiment on 600 black men from low-income rural areas without their informed consent. In 1935, Herman Shaw, a patient in the Tuskegee, was finally informed that he was receiving treatment for syphilis, an experiment he did not give consent to. The apology, however, was given more than 6 decades after the injustice. In 1977, President Clinton and Vice President Al Gore apologized to Herman Shaw. He was 94 years old then. Shaw stood in the East Room of the White House and declared, "It is never too late to work to restore faith and trust. What was done cannot be undone. What we can end the silence," Clinton said. "We can stop turning our heads away. We can look at you in the eye and finally say, on behalf of the American people, what the United States government did was shameful, and I am sorry." In 1951, a woman named Henrietta Lacks was diagnosed with cervical cancer. She was 31 years old. During her treatment, doctors took cells from her body and discovered they lived long lives and reproduced indefinitely in test tubes. These immortal hello cells have since contributed to over 10,000 medical patents and aiding research. It is important to note that these cells were taken without her permission, and neither she nor her family were consulted or compensated for their ongoing use in medical research for decades to follow. In 1965, the Voting Rights Act was signed into law to secure the right to vote for racial minorities throughout the country. Additionally, the Medicare and Medicaid Act was passed in the same bill. This hidden milestone made it illegal to provide federal funding to any hospital or medical practice that excluded racial and ethnic minorities. However, the regulation was not enforced, and most blacks still received medical services from poorly funded medical public hospitals and clinics. This event went unnoticed in history. Black Panther Party chapters in Kansas City, Chicago, and Seattle established the first People's Free Medical Clinic. They also held a sickle cell testing drive at the Civic Auditorium right here in San Francisco. Alongside, they initiated a door-to-door testing program for diseases like TB and diabetes. The legacy continues today with federally supported programs, including the free lunch program in school, free busing to prison programs, and free clinics. The Black Panther Party was able to achieve these tasks through contributions from individuals such as Cleo Silvers. She joined the Black Panther Party as a healthcare volunteer. While Cleo Silvers was integral to Black Panther Party's mission to provide healthcare, her work did not end with the party. Years later, during the COVID-19 pandemic, when Cleo Silvers heard that black people were dying at 3 times the rate of whites due to social determinants of health, she joined the Black Doctors COVID-19 consortium that tested more than 26,000 people. In 1971, the NBNA was founded. I will hold for a moment for everyone to be able to look at the individuals in the picture. The NBNA Association has addressed racism in several ways. Black nurses face significant discrimination and limited advancement opportunities in the profession at the time. They serve as the voice for black nurses and promote equal access to professional development and education. They address racism through promoting diversity and cultural competence, advocating for policies to address systemic racism, provide scholarships and resources, and collaboration with other organizations to address racism in healthcare. We now fast forward to the year 2010. The Affordable Care Act was passed, providing health insurance to 20 million previously uninsured Americans. In 2016, a study by Hoffman and colleagues revealed that false beliefs about biological differences between blacks and whites are held by many white laypeople, medical students, and residents. These beliefs contribute to racial bias in pain perception and treatment recommendations, affecting the way black people are perceived and treated. In 2019, a study by Dr. Mary Finling and colleagues reported that 23% of Native Americans reported experiences discrimination in clinical encounters, and 15% avoided seeking health care due to anticipated discrimination. Using race in clinical calculators and screening metrics may worsen health disparities, as reported in a study Hidden in Plain Sight, reconsidering the use of race correction in clinical algorithms. Study that has been published in New England Journal of Sports Medicine, the issue of race correction. Race correction may lead to more attention and resources being given to white patients over minorities, contributing to health disparities. The authors of the study urged reconsideration of the use of race correction in clinical algorithms and provided examples of equity concerns. We hope to bring future direction of health equity research by moving away from observational research and identify mechanisms and pathways that can explain how social determinants impact health and lead to health disparities. We hope to establish community and interdisciplinary research partnerships to shorten the translational research to service gap. We hope to focus on strengthening recruitment, representativeness, and generalizability. We'd like to conclude this presentation by highlighting a few points. Racism in medicine is a historical continuum that continuously affects African American and ethnic minority health and how they receive health care. The conceptualization of race moved from the biological to the sociological sphere with the march of science. By learning about the past, today's medical practitioners will be better armed to discern and correct the ways in which contemporary medicine perpetuates historical injustices. The road towards health equity to improve quality care and remove the damaging influence of racism in medicine requires an all-hands-on approach. Our determination to progress gives us the optimism for a brighter, equitable future in medicine. We also like to acknowledge Carol Yoon, Project Manager, Division of Health Equity Research, for the contributions to this presentation. Thank you, and we wish you a great conference.